Hello, everyone. It's my privilege to be here to join you in this Brain Awareness Week in Zambia. And my name is Stephen VanHaerents. I'm a neurologist at Northwestern University and Northwestern Memorial Hospital, which is in Chicago in the United States. And if you've not been there, this is a picture of it, and it is a beautiful city if you have a chance to visit. So in my field of epilepsy, I have a subspecialty interest in autoimmune epilepsy, and that's what I have the honor of speaking with you today about. So what are the objectives for this talk? So there's a number of different objectives in understanding who gets it and what is autoimmune epilepsy, but the real key thing is how to think about when someone might be autoimmune or how to diagnose it, which can be quite challenging. I do have some disclosures for this talk, but the big one in the United States is that the treatments for this, there is no FDA in the United States that approves any treatments for this. So everything is actually really off-label, and that's the main disclosure. So before really getting into what autoimmune epilepsy is, I think it's best to kind of just walk through a case and use that case as a framework for how we discuss what is autoimmune epilepsy. So this is a patient of mine. He's a 69-year-old man, and on Labor Day weekend, which is in September in the United States, in 2014, he was noted to be confused. His neighbor and friend initially saw him, and then a few hours later returned and thought he must have woken up from sleep and seemed out of it. When his wife came home from a trip and found him to be very confused, he was unable to remember that any family deaths or any events from the day before. And so she was very alarmed, and she took him to an emergency room. Not at my hospital, but another hospital in the city of Chicago. They did a CT of the head, an MRI of the head, and they did a 30-minute EEG, really concerned at the time that he might be having a stroke, all of which were normal, and he was discharged home, but he didn't get any better. In fact, his difficulty with memory continued to progress, and he continued to do worse. He was no longer really able to effectively work, and he had to plan retirement early. He continued to not remember the deaths of his parents when he definitely would have prior to this event. He was also sleeping less. He was staying up till about 5 a.m. in the morning when he would strictly be in bed by midnight previously. He was losing weight, and what we referred to as our ADLs, just can he do like advanced tasks around the house? And he really couldn't anymore. And his behavior and mood had also changed. He was becoming more irritable and aggressive. At times, he even left bruises on his wife's arms, which was not his personality at all. He was never aggressive. He was also more affectionate than usual and reported some low and depressed mood. He had also developed some obsessive compulsive type behaviors, having to check and double check things repeatedly before leaving the house. He was also having what he described as panic attacks. And he believed that these might have actually started years prior to this substantial cognitive decline. And he thinks that they were happening about 20 to 30 times per day now. He would breathe heavy and words were hard to get out. And he would notice that his face kind of pulled into a frown, and he looked like he was about to cry. It would last seconds, and he thought that they were triggered by maybe realizing his memory was poor or forgetting things. He was also getting goosebumps really frequently, and he would start to breathe, and then it looked like he was going to cry. He said it felt like an adrenaline rush. But other than that, he really had an unremarkable history. And so on his exam, when he first presented to our hospital, he had a little bit of a low temperature, and his, mental status exam, he was a little almost pressured, where he was very verbose and speaking a lot and very tangential, but it kind of circumferential where he couldn't get to the point. His repetition and naming were intact, but really his recall, his ability to really form memories and then retrieve them was impaired. So he could only get 1 out of 3 objects, but 3 out of 3 with hints, pointing at a kind of impaired retrieval. He also, he was attentive though. He was able to say the months of the year forward, but saying them backwards was accurate. And then during the visit, he had several episodes of kind of rapid breathing, and his mouth would kind of turn into a frown. And then he would sort of forget what he had been talking about and what task he had been doing before the spell. And the rest of his neurologic exam was really unremarkable. So when thinking about a patient like this, what would your differential be? What do you want to do? And what are you going to tell the patient and his family? So before answering these questions, let's do a review. And given that this is an autoimmune lecture, it's likely he's going to end up with an autoimmune epilepsy. So let's kind of review what that even means. So what are these autoimmune epilepsies? So these are all kind of lumped together, these antibody-associated CNS autoimmune disorders. And they're related and overlapping. Some people will say autoimmune encephalopathy, some people say autoimmune dementia, and some people say like autoimmune epilepsy, but it's really just what the prominent feature is, because it depends on what the antibodies are directed to of what their main symptoms and disease will be. So if it's affecting the cortex, seizures is often happens, but can also affect and give you neuropathy, or it depends where the antibodies are actually targeted and what their target is. And this has been a rapidly expanding field. When you really look at like PubMed queries throughout the year, it's really exponentially increasing. And we're further discovering more about these antibodies and their targets in different syndromes. So when we think about them, let's just define some terms. So let's break it down: paraneoplastic versus non-paraneoplastic, and limbic versus non-limbic when you're talking about autoimmune encephalitis. So when we refer to paraneoplastic, we're referring to a heterogeneous group of neurologic disorders associated with like cancer and caused by mechanisms other than just, brain metastases in the brain or spinal cord, and not like metabolic, like, bone breakdown and high calcium, nutritional deficits, infection, coagulopathy. All of these are things that people with cancer can have, but are not really referred to as paraneoplastic. It's usually more related to the immune system and can affect any part of the nervous system, from the cerebral cortex to the neuromuscular junction, and can damage one or multiple areas. Now, what is the limbic system when we refer to limbic encephalitis or non-limbic encephalitis? So this is what I teach my medical students at Northwestern, this mnemonic of home. And this is really what the limbic system does. It's this, 3-layered old part of the brain that has its own antigens. And so certain viruses and antibodies are directed to the limbic system. And it includes things like the hypothalamus with your homeostatic functions, olfaction, memory with the hippocampal formation, and emotions and drives with the amygdala. So when people are like, what does a limbic encephalitis do? It really does all of these things. It produces cognitive impairment, perception, mood changes, sleep disturbances, and it can be also, they can have findings beyond just the limbic system. So let's do some neuroanatomy. And, I'm a clinician, and so I'm not a basic scientist, but it's important to really understand things at a cellular level because it affects the treatment. So when you're looking at who gets these autoimmune diseases, we just spoke about paraneoplastic causes. And let me just turn on a laser pointer here. So we talked about paraneoplastic causes, often with molecular mimicry, for instance, where your immune system's trying to attack the cancer, but in doing so starts attacking yourself. Then certain viruses, especially like herpes simplex virus, This has been well described in animal models now and clinically, where patients can get like an HSV encephalitis and then can then develop an anti-NMDA receptor encephalitis. That's kind of a classic example. But a large portion of them, we actually don't know why they develop these antibodies. And some of them just have kind of this autoimmune tendency or family history of a lot of autoimmune diseases and just seem more predisposed to that. And so now we can break this into kind of two different families of autoimmune diseases. You have those that are cell surface antibodies. So these are like antibodies that are directly toxic and bind on proteins that are on the cell surface. And these are directly toxic antibodies. The other family are intracellular antibodies. So these antibodies, like for instance, like GAD65 is an intracellular protein. And so the antibodies actually are more just markers of destruction. So when you're thinking about these like B cell, this would be like voltage gated potassium, NMDA, and the antibody is directly pathogenic, as opposed to these, which are going to be more T cell driven, where the antibody is more a marker of intracellular like injury, or like not intracellular injury, but just cellular injury in general. And we'll talk about, but the treatments are going to be different. With these intracellular, you're going to want to target more T cells as well, especially if very ill with things like cyclophosphamide. So when thinking about these different antibodies, we'll break them into two families instead of going through each antibody individually. And so that's cell surface, you may recognize some of these antibodies like voltage-gated potassium, which can be subtyped into LGI1 or CASP-R antibodies. And then there's NMDA receptor encephalitis, AMPA, GABA, mGlu-R5, DPPX, the voltage-gated calcium, the nicotinic acetylcholine receptor. All of these are going to be more cell surface as opposed to intracellular. And the intracellular are almost always paraneoplastic, except for GAD65. GAD65 is rarely paraneoplastic, but these are like anti-HU, MA, which is highly associated with like testicular cancer, CRMP5, amphophyssin, and amphophyssin also may be directly pathogenic as well. And these often have a very limited response to immunotherapy. And when you think of what cancer is the most common, it's almost always small cell cancer for most antibodies. So now let's just kind of go into these acute symptomatic seizures secondary to autoimmune encephalitis and autoimmune epilepsy, because this is really an epilepsy talk at its core. So seizures are well recognized and often a very prominent manifestation of autoimmune encephalitic syndromes. Patients with systemic autoimmune disorders are at increased risk of seizures, and the term autoimmune epilepsy was initially suggested as a concept in 2002 with kind of like emerging body of evidence suggesting that autoimmune mechanisms in a subset of patients with epilepsy. So the ILAE, the International League Against Epilepsy definitions, now has this category of an immune etiology for epilepsy. However, many patients with cell surface antibodies can also achieve seizure freedom with treatment and immune suppression. And so this is kind of counter to the whole concept of epilepsy, which is this enduring predisposition to unprovoked seizures. So let's kind of break this down into two other categories. So there's kind of acute symptomatic seizures secondary to autoimmune encephalitis, and then ongoing autoimmune associated epilepsy. So what do I mean by these? So acute symptomatic seizures secondary to autoimmune encephalitis, these are usually those cell surface antibodies like NMDA receptor encephalitis, LGI1. And if you get to them early and have an immune suppression early, they often will not have, you can cure them of their seizures if you get to them early. And it's thought that these antibodies, it's more of an antibody-mediated ictogenesis, and they respond very well to immunotherapy, but anti-seizure meds in isolation are usually ineffective. And seizures usually terminate with the remission of the encephalitis, and it has the potential for anti-seizure medications to be discontinued altogether, but they might have some enduring cognitive deficits. As opposed to an autoimmune-associated epilepsy, these are often those intracellular antigens like the onconeuronal paraneoplastic ones, or GAD65, Rasmussen's encephalitis, and these patients develop a lot of structural injury. And so due to this kind of like post-encephalitic pathology and this T cell mediated brain inflammation. Unfortunately, these patients, anti-seizure medications alone are often ineffective. Epilepsy surgery has usually an incomplete response, and immunotherapy also with a poor response. They're very difficult to treat, and I have a lot of them in clinic, and they tend to be very resistant to medications and have a kind of potential enduring cognitive deficits. So let's talk about these acute symptomatic seizures in a little bit more detail first. And this is looking at a paper looking at like 3-year follow-up. And you can see that this first, the green, is when you got seizures to stop, the last seizure to stop, and then when you were able to come off seizure meds. And you can see with the cell surface, seizure freedom was achieved after additional immunotherapy, but with the intracellular ones, not so much. And each notch is a year. And so let's talk about what autoimmune seizures are like and when you should think that maybe this patient's epilepsy is actually autoimmune in etiology. So one key thing is early medical intractability, where it's not typical in most epilepsies where you start meds and they're immediately refractory, like seizing very frequently. They usually have a lack of other epilepsy risk factors. There's not a stroke unless it's like vasculitis, but they usually don't have had febrile seizures or family history of epilepsy. They usually have high seizure frequency and very short duration with a lack of post-ictal confusion. So a lot of seizures, but they come out of them pretty quick. If you ever see like status epilepticus at onset, like with GABA receptor encephalitis, that's very common. Or like changing seizure types, or like epilepsy partialis continua, for instance, just like at onset without like some clear structural cause. The ictal EEG is often distributed beyond the temporal lobes, and there's specific antibody associations. For instance, LGI1 encephalitis can give you these facial brachial dystonic seizures where you, and I'll show you a video of those, where your face can get kind of pulled or you get these quick kind of arm. GAD65 antibodies can also lead to musicogenic epilepsy, which I have seen that as well. And then perisylvian semiology tends to be very frequently seen in autoimmune seizures. So what is the perisylvian semiology? So this is another paper from Gillinder in Australia with common kind of features with these kind of perisylvian. And almost all the patients in this had anti-GAD65 encephalitis. But when you see this kind of like perisylvian region along the medial temporal lobe or insula, they can get like somatosensory seizures, viscerosensitive sensory seizures, auditory, language, autonomic with like tachycardia, bradycardia, kind of piloerection, flushing. And so all of these we kind of think of as perisylvian. So let's take a look at one of these facial brachial seizures. One second, why is it not pulling? There we go. So in this video, so this is a guy, and you can see right here, he gets these brief kind of tonic contractions. And this is an EEG, not of the same patient, but they often actually don't have correlate on the EEG. But if they do, they can get this kind of attenuation of the EEG. But that's an example of a facial brachial dystonic seizure, which is associated with LGI1 encephalitis. So why is this such a difficult diagnosis to make? Well, it's rare. Well, it's probably not as rare as we think. It's, the more we look for it, the more we're finding it. And this is from the Mayo Clinic in Minnesota in the United States that showed that the prevalence and incidence of autoimmune encephalitis was comparable to infectious encephalitis. And its detection is increasing over time the more we look for it. The heterogeneity of clinical presentations. That's true, but the more we're learning about individual antibodies, the more similar some are starting to find out. Send out panels in the United States have a lot of different panels that check a lot of different antibodies, and some of them aren't always as comprehensive, and you might have false negatives. Sometimes you can have false positives as well. And it can take a long time to actually get the results. And, we're fooling ourselves if we think we know every antibody at this point. You can definitely have antibody negative disease as well. And sometimes very low titers of antibodies, can be a false positive, and they might not have any autoimmune encephalitis. Particularly like in the blood, if you're checking like GAD65 or like a non-LGI1 or CASP-R in the blood. And it can sometimes mimic or exclude alternative diagnoses like mitochondrial diseases, for example. So these are kind of clues that cue me into an autoimmune etiology, like change in baseline neurologic function, like subacute onset, a fluctuating course, a personal or family history of like autoimmune disorders. They might have other like systemic markers of autoimmune, like a high ANA, like you would see in rheumatoid or like lupus, or anti-TPO antibodies, which you can see with like Hashimoto's. They might have a malignancy. You get CSF and it has signs of inflammation, usually not super high, like usually less than 100 white blood cells. But sometimes the CSF really doesn't show anything. Or maybe just elevated protein, or they have EEG, MRI, PET brain, or they just respond to immunotherapy. So all of those kind of cue you in. And this is a paper from our institution where we looked at in our cohort just how sensitive are these paraclinical markers. So we looked at like TPO antibodies, thyroglobulin antibodies, ANA, and we found that they were commonly elevated paraclinical markers. And at least one of the three markers is present in 68% of our autoimmune encephalitis patients. So not super sensitive or specific, but nice to see while you're waiting for a panel and might help guide you in this direction or cue you in. So let's go through an algorithmic approach and then we'll go back to my clinic patient. So this is kind of the autoimmune like workup, that specific workup that I usually do when I'm suspecting autoimmune. So I get their blood and I usually check for an ANA, TPO, and I will try and send a neuronal like autoimmune antibody panel. And then in the spinal fluid, I look for white blood cells, protein, IgG index, and synthesis rate, and I look for oligoclonal bands, all of these, especially if there's very subtle signs of inflammation. On the brain MRI, I'm looking for like 2-2 sequence flare hyperintensities, or like some enhancement. On the EEG, maybe I'm looking for focal spikes, or like in certain patterns like NMDA receptor encephalitis, you can get this extreme delta brush. And if you're able to get a PET MRI, which can be very expensive, you can see like hypo or hypermetabolism. And then I screen for cancer. And so that's the basic workup. Now, let's kind of go through some caveats. You want to really get to know your panels. Other antibodies that are not as commonly that we haven't really talked about, like anti-MOG, where we think of demyelination, can also be associated with seizure. Same thing with GFAP. In the United States, I avoid terms of paraneoplastic panels because those are usually just the antibodies that are associated with cancer. And so you're not casting a broad enough net. And I never order individual antibodies. Like even like LGI1, I always order panels because you can have multiple antibodies and that might affect how you discuss the risk for an underlying cancer and how aggressively you want to screen for cancer. And, just getting to know that I usually try to send them to labs that are involved in research because we don't know all the antibodies yet. And they can look and see if there's any autoreactivity on the brain's samples. And I always get both blood and spinal fluid because sometimes you can have false negatives in the blood. Like for instance, NMDA antibodies might not be positive in the blood and only positive in the CSF. But the cerebral spinal fluid might be negative in voltage-gated potassium like LGI1 and CASP-R. So I always try to get both. And GAD65, particularly in you want the CSF, because it can be in the blood at low titers, and we really don't know if that has any neurologic relevance. And if you're able to get to a PET scanner, it can detect more malignancies, and 20% of those suspected to be paraneoplastic, where like a CT, which is more commonly done, was negative. So this is what I was kind of referring to, that you really want to be careful if the spinal fluid doesn't have a lot of white blood cells in it. So this is from in Canada, in Montreal area, or it's in Quebec, I should say, where they looked at spinal fluid samples, and they found that 18% really had only high protein. 24% had, the elevated cells. 29% had both elevated cells and protein, but 25% were normal. If you included oligoclonal bands, that was another 14%. But beware if the spinal fluid looks normal, that doesn't automatically exclude a autoimmune cause. So there's also, I want you to be aware that there are predictive tools for autoimmune seizures. So I like to use this APE2 score, the antibody prevalence in epilepsy score, which was developed at the Mayo Clinic with Dr. Dubé. And then there's the response to immunotherapy, the RIGHT2 score. And while this looks really overwhelming, it's really kind of just a way to organize your thoughts of when to suspect an autoimmune etiology. Like, do you have new onset, rapidly progressive mental status changes that developed over 1 to 6 weeks, or new onset seizure activity within 1 year? Neuropsychiatric changes like agitation, aggressiveness, autonomic dysfunction, with like sustained tachycardia, bradycardia, large changes in blood pressure? Did they have this kind of viral prodrome? Do they have these facial brachial dystonic seizures that we were talking about, which you see like with LGI1 encephalitis, or like facial dyskinesias where they make lots of facial movements? You see that in NMDA receptor encephalitis. Are the seizures refractory to at least 2 seizure medications? Did they have signs of inflammation on their CSF? Does their brain MRI, is that suggestive of an encephalitis? Is there any underlying cancer? And then you take this and you score it, you add them together. And with the right score, if it's greater than 7, that would be more sensitive that you would have a response to immunotherapy. Well, an APE score, if you don't have, this is like, what is the likelihood you're going to get a positive antibody? And so you want to score a 4 or more to have like a good sensitivity and a relatively good specificity as well. And so this is kind of a flow chart from Dr. Dubé that I kind of use. And so when I'm working up someone, like I look at kind of the APEE2 score during the workup. And let's say you can't get antibodies, or, the antibodies you're still pending, that's when, if you're kind of on the fence, you might want to just try them immunotherapy and see if they respond. And so anti-seizure meds, let's just briefly talk about this too. So autoimmune epilepsy is characteristically very resistant to anti-seizure medication. And this is a retrospective review of really looking at like LGI1, NMDA, R, and GABA receptor as well. And 89% reached seizure freedom in this group, but 53% achieved seizure freedom shortly after immunotherapy. Only 14% were able to achieve seizure freedom while only using epileptic drugs or anti-seizure drugs. And the development of epilepsy after the encephalitis had resolved was rare after the treatment of immunotherapy. Of note, carbamazepine was better than levetiracetam in reducing seizures in the LGI-1 encephalitis group. And only one patient of the 86 surviving patients developed epilepsy after the resolved encephalitis. And so, which has also been kind of reported in other articles. And so the moral is you want to start early and add immunotherapy. So this is looking at facial brachial dystonic seizures. And I think this is the most staggering of the data in that when you look at it, the delay in starting immunotherapy has this decay that this is the likelihood that this facial brachial dystonic seizures will stop. And the longer you delay treatment, the less likely you will be able to get rid of these seizures. So it's important to start early and add immunotherapy. So now that we've kind of talked about what is autoimmune epilepsy and autoimmune encephalitis, let's go back and finish the case that we were talking about. So the patient, if you remember, was an older gentleman who presented acutely in September with mental status changes, poor memory, behavioral changes, and he was also having these what he called panic attacks, where he'd feel this kind of adrenaline rush, and sometimes he would feel like his face get kind of pulled down, and his wife thought it was like he was about to cry. But really, now that we know more about these facial-brachial dystonic seizures, they were actually all little facial-brachial dystonic seizures. And so when we initially got his blood work, his sodium was actually pretty low, which you can also see with LGI-1 encephalitis. His spinal fluid actually had it was really not that inflammatory. It had one white blood cell, which is really normal. And there was really, he had some atrophy in his brain, but nothing really overtly inflammatory. And so when we put him on EEG, I'm not sure how many in the audience know how to read EEG, but the odd numbers are the left side of his brain and the even numbers are the right side. And you can see this kind of hypersynchronization and this evolution into a right temporal lobe seizure on this page. And then right after that, he has a left temporal lobe seizure. And basically he was having very frequent seizures. And so given this is an autoimmune lecture, I kind of already told you if you could guess the antibody, but since this is pre-recorded, I just told you, and it's LGI-1 encephalitis. And so he had this anti-voltage gated potassium subtype to the LGI-1. And so that eventually did come back. I did screen him for cancer and with a CT of his chest, his abdomen and pelvis. And we actually did a PET scan as well. And there was no underlying cancer found. So what do you want to do? And I know we didn't, for the sake of time, go into the nuance of treatment, but for him, we ended up doing something called plasmapheresis and trying to wash the antibody out of his blood. And then he got high-dose steroids and intravenous immunoglobulin therapy as well over 5 days. And then he continued on some intravenous immunoglobulins and steroids, and he really recovered. By 12 weeks, he was able to slowly come off. And he actually needed some antipsychotics because he was so agitated. He was able to come off all of those. And then when we did cognitive testing on him, he had improved executive and behavioral functioning, but still with some cognitive difficulties. But he was on valproic acid, but he developed some Parkinsonian symptoms. And so he was switched to levetiracetam twice a day for a seizure medication. And that's really the conclusion of the talk. And I'm happy to take any questions. And it was a privilege to talk to you all today. All right, thank you. Oh, and I would like to thank the following people for aid in the slides, and then I have several references as well. All right, thank you.